And now I'll invite the next speaker, Dr. Nilesh, doctor, for the salvage procedure for chronic pancreatitis.
Hi, good afternoon, everybody. Thank the organizers and the chairperson for inviting me to present at this meeting. So I have tried to cover a few points. I think Dr. Ramesh was already asked during his talk what to do with patients who have got problems. So in my talk, I'm going to try and cover when to try and kind of salvage a patient. When does this patient need salvage after chronic pancreatitis, and what procedures we can do to help them. So the large majority of patients we're going to deal with is the patients who've got recurrent pain after surgery for chronic pancreatitis. And I'm going to deal with some other stent-related issues, pseudoaneurysms in chronic pancreatitis, and intraoperative problems that you can see, and those patients may need salvage. So recurrent pain, in the first two talks, there's been a lot of discussion about recurrent pain. And it is true that there are some patients, maybe 20% of them, who after 10 years may get pain. And these are the patients who we need to very carefully evaluate, because some of these patients may just be due to either opiate use, or if they've got small duct disease which is persistent, or they've had major postoperative complications, and these are all predictors in several series. So Adarsh is one series. There are several other series which have talked about recurrent pain and quality of life issues 8 to 10 years after surgery, and about 20-25% of patients do seem to have this problem. So carefully go through what are the causes of the pain. So it could be that there is an inadequate surgery, or there are the other issues, like if the patient has had a lot of opiates prior to the surgery, or the patient has gone back to alcohol or nicotine abuse. These could be causes. Obviously, these are not surgical causes, and it's very difficult to offer any procedure as a salvage operation. In those patients, you need to have a whole team of people who are going to address these issues so that you can try and solve them. And after all the other pathologies are ruled out in the upper abdomen, as Ramesh alluded to, about 15-20% of the patients who've got recurrent pain may actually be candidates for a procedure. So you need to figure out which of these patients who've got recurrent pain can actually benefit from a procedure. So you look at the pattern of pain, Rulu problems, undrained segments on imaging, stones, if you see any residual large stones, head mass, inflammatory head mass, any signs of inflammation like rising CRP or symptoms of inflammation, any biliary obstruction, or any suspicion of malignancy. So reoperative surgery, there have been a lot of data right from 1994 which suggests that it's pretty safe. So the important thing is that, people say that the pancreatic surgery itself is unsafe. Bismuth had very clearly said in his opening statement when he wrote the first book on pancreas in 1982, the pancreas is not your friend. So is it your friend the second time on? So there are a lot of studies which say that reoperative surgery is pretty safe in patients, in surgeons who are experienced in this. So it's important now to be able to plan the type of redo surgery and try to tailor it to the patient for the problem he has. So it could easily be divided into either a drainage surgery or a resectional surgery, and total pancreatectomy for a few patients who are especially bad diabetics, where you can do an islet cell transplantation. This is predominantly done in the West. There are not many centers which do it here, but predominantly majority of these patients are ideally best drained again. Resection or with a distal pancreatectomy or Whipple should be, as far as possible, avoided. So you can see the early series, Washaw series, they did a lot of resectional studies, resectional operations in patients. But this was because at that time, the drainage operation itself, the first time around, was never an adequate operation. It was usually a lateral pancreatic jejunostomy, which did not address the head. So many of these patients landed up as the second operation having a Whipple's or a resectional surgery. Adams in 2010 and Madura recently have suggested that more than 2/3 or 80% of patients actually will benefit from drainage rather than from any resection. So here you can see what the speaker had alluded to earlier. You can see that there is the arrow is pointing towards is there a pointer here? Towards the undrained. So you can see that the entire duct has been drained here. But you can see that there's a large portion of the tail which has been undrained. So I think it's important to mobilize the pancreas, as he said earlier, so that this doesn't get left behind, and this can easily be tackled either with a distal resection or with a redrainage. Here you can see that this surgeon is obviously opened this whole duct and done a drainage procedure, but there was a tight stricture here, and there is a cyst here and quite a long length of dilated duct system which has not been tackled at the first surgery, and these patients are very suitable and amenable for redrainage. So if you have a missed ducts, anastomotic stricture, or only a lateral pancreatic jejunostomy done and a lot of stones, these patients are more amenable to drainage. But if you have a head mass or a biliary stricture, left-sided portal hypertension, or pseudoaneurysms in the left system, these are more amenable for resectional procedures. Celiac plexus neurolysis is again a salvage procedure. Unfortunately, this has really had a mixed career. There was a lot of excitement in celiac plexus neurolysis for failed pain relief, but recent meta-analysis shows that this is a very big mixed bag of patients with pancreatic cancer and chronic pancreatitis, and really there is a 50% pain relief reported, but many of these studies are very short-term for 3 or 4 months, and you don't know what happens to them later. Stent migration, infection, and pain. So I'm going to talk about salvage procedures now in patients who had stent-related problems. So you can see here that there is a stent migrated into the pancreatic duct, and the patient has gone on to develop sepsis. There is a fluid collection here. You can see perisplenic fluid. So this patient had severe pain following stent migration. The stent could not be removed, and the patient finally landed up with a distal resection. Here you can see that there is again stent-related sepsis. This patient had extensive collection all the way down into the left paracolic gutter. Here we had to wait for 3 months. We had to put in a pigtail catheter, drain the infection, allow it to settle down, and then plan the drainage procedure. So here you can see that many of these stents fragment inside. I must thank Ramesh here for having lent some of these slides to me. You can see that there is concretions around the stent here which can actually worsen the situation. If the stents are left for a long time, you can see that stones start forming around the stent, and the patient gets more and more pain. Splenic artery pseudoaneurysm. Again, this is a patient who had stenting and developed sepsis in the tail of the pancreas. So you can see the contrast CT which is showing contrast extravasation into the cyst. And splenic artery pseudoaneurysm you can see in the arterial phase of the CT. Here again there is a stent sepsis, and which has caused this collection and formed a pseudoaneurysm. So we had to do a transarterial embolization and then plan the procedure for doing a distal pancreatectomy and drain the main pancreatic duct for as a salvage procedure. Similarly, here you can see that severe stent-related sepsis has caused a splenic abscess and a rupture of the spleen, and patient had to have an emergency surgery as a salvage procedure in chronic pancreatitis. Here you can see attempts at ESWL therapy. So here again you can see that patient has had shock therapy for the stones, but you can see that the patient did not have pain relief and all the stones remained impacted in the duct, and it was very difficult to do a head coring in this patient. Capsular rupture, we published this data in pancreatology a few years ago, where we found that if you accidentally open the pancreatic, so if you want to do a salvage, where supposing there is bleeding from the splenic vein at the back, or there is a rupture when you're doing a Frey procedure in the back of the capsule, you can actually just suture it and proceed with your anastomosis. Rule loop problems, this also we published just a few months ago. So look for patients who have got intermittent pain and vomiting. So out of our series of more than 150 odd pancreatic jejunostomy, we found 5 patients. You can see here, the CT shows a dilated loop, and here you can see that there is a whirling of the mesentery. So these patients get intermittent rule loop obstruction, and these patients are also very much amenable to salvage surgery. So in conclusion, salvage therapy can be difficult, but patient selection is the key, and about a third of patients who got recurrent pain can really benefit from salvage treatment, especially a redrainage procedure. Conservative treatment is initially important to stabilize the patient, especially if they've got stent-related infection. Don't jump into surgery immediately till the sepsis is resolved. And surgery can be very safe and effective. Thank you very much.
Nilesh, any questions, please?
Can I make a comment? Sir, you already alluded to the possibility of masses in a patient who is operated for chronic pancreatitis. And we must always remember that chronic pancreatitis itself is a risk factor for malignancy. recently saw a young patient who was operated 6 years back for LPJ, and he had a mass lesion in the, came with persistent pain, and he had a mass lesion in the tail which was missed on CT as well as EUS. He had fluid collections as well, and his CA 19-9 was 6,000, and then subsequently actually it turned out to be a metastatic disease. But this mass or a presence of adenocarcinoma even in operated patients should be kept in mind when we are dealing with persistent pain. I am not sure whether that falls into the category of salvage procedures. But
yes, I have actually mentioned it doesn't probably, it's a different disease, but I have mentioned here the type of pain that you see post-op is very important, and the persistence of the pain that's radiating to the back associated with weight loss, tumor markers. So there are a lot of pointers which tell you, and imaging is the key. You know, on imaging, if you see any inflammatory head mass or a suspicious lesion for malignancy, obviously, you know, you've got to treat it differently.
Sir, my query is on total pancreatectomy and autologous islet cell transplantation in chronic pancreatitis, because in most of our studies with light microscopy and electron microscopy has shown that the islet cells are totally destroyed in chronic pancreatitis. In that situation, how do you plan such a treatment?
I actually don't have much experience with that, but when I read the literature, the yield of patients for islet cells is quite high. Having said that, the number of patients, so the real answer to your question is in the number of patients who are going to not require insulin, okay? So after you do successful islet cell transplantation in chronic pancreatitis patients, having retrieved islet cells from this diseased pancreas, about 20% are free from insulin, and the remaining need insulin, but have a much better control of their diabetes if they, compared to if they didn't have any islet cell transplant. So the approximate number of islet cells that they got was about 45 or 50,000. So it's not an insubstantial number. You can get sufficient islet cells to transplant back, even from a diseased gland. So if you're doing a total pancreatectomy for chronic pancreatitis, you can get a much better glycemic control than if you didn't do it.
Yeah, I can share the pictures
Ramesh wants to add something.
Yes.
No, I'm somewhat bemused by this statement because the C-peptide level in patients with idiopathic chronic pancreatitis is within normal limits. The C-peptide is a surrogate marker of the insulin secreting capacity of the pancreas. And that itself is testimony to the fact that the absolute number of islets is the same in idiopathic chronic pancreatitis, but their release into the circulation is hampered, or maybe the end organ receptor is inactive. In fact, Nagalotimath and Balraman Nair from our state showed, Nagalotimath was in Karnataka, Hubli, they showed that if you take even a light microscopic picture of chronic pancreatitis, you find pseudo-nisidioblastosis, and yet patients have type 3C diabetes.
Yes.
So may I know the source of your statement that EM shows no islets at all? I'm really bemused by that.
No, sir, I didn't say no islets, but the electron microscopic study that we have published in pancreas, that shows extensive fibrosis around these islet cells also.
Yes. So the islets are present. The islets are actually more prominent than before, that perhaps they release into the circulation. Even in Western literature, Howard Reber published a paper of how you could just, you know, lay open the gland, get some neovascularization into a fibrotic gland, and actually get amelioration of diabetes. So that's not a global phenomenon, of course, but the fact is that in patients with idiopathic chronic pancreatitis, the pancreatic islets seem to be preserved. However, the patients are still insulin dependent. They have a type 3C diabetes.
No, and the studies clearly demonstrate that there is very good long-term glycemic control in the patients.
The bigger problem, Nilesh, is in centers in Coimbatore and in Delhi are doing islet cell extraction. In our, they say, and we did not start it because we didn't think we had the wherewithal for that, but the extensive fibrosis prevents the, you know, they use, I think, dimethyl sulfoxide as a medium, and they use cryocentrifugation, and therefore they had great difficulty in taking the islets. That is a different thing from their not being there. So I just want to make things clear.
Thank you, everyone. Now we'll conclude the session.
Okay, thank you.